Welcome again. We are talking about the vascular development in the cardiovascular system, and this section is about arterial system. In this section, we'll be talking about the vitelline and the umbilical veins, the coronary arteries, their development, and how and what happens if the developmental process goes wrong. So, first of all, the vitelline arteries. So, before getting into the detail of the vitelline arteries are these. This is the vitelline artery. These paired arteries are the vitelline arteries here in black. So initially there are a number of pair arteries. These are the number of pair arteries which are supplying the yolk sac. They are supplying the yolk sac. So gradually form and fuse arteries in the dorsal mesentery of gut. So now they gradually fuse. These are them fusing, and they form arteries in the dorsal mesentery of the gut. This is the region of the dorsal mesentery, and here they gradually fuse and form the arteries in the gut. So in adult, they are represented by celiac and superior mesenteric artery. So in adult, the blood supply, these vitelline arteries, they represent the celiac and the superior mesenteric artery, which are the blood supply of the foregut and the midgut respectively. The inferior mesenteric artery, it arises from the umbilical arteries. Here you can see these are the this is the umbilical artery, and the inferior mesenteric artery, which is the blood supply of the hindgut, it develops from umbilical artery. So talking about the umbilical arteries, here you can see these are the umbilical arteries in blue. They're initially paired branches of the dorsal aorta. So they are two in number, and they are branches of the dorsal aorta. During the fourth week, each artery acquires a secondary connection. Here you can see these arteries are acquiring a secondary connection with the dorsal branch of the aorta, which is the common iliac artery. So, during the fourth week of development, these branches, these umbilical arteries tend to have secondary connection with the dorsal branch of the aorta, which is the common iliac artery. So they lose their earlier origin. Obviously, since they have developed new origins, now they lose their earlier origin. So now they're not a part of a dorsal aorta, but they do not contain a connection. They do not have a connection with the dorsal aorta anymore, but with the terminal branch of the dorsal branch of the dorsal aorta, which is the common iliac artery. Now, after birth, what happens to these umbilical arteries after birth? The proximal part of the umbilical arteries, these are the proximal parts. They persist as the internal iliac as well as the superior vesicular or the gonadal arteries, and the distal parts. So these are the distal parts. They obliterate and form the medial umbilical ligament because they were going into the placenta. The placenta is no longer there after birth, so they obliterate and form the medial umbilical ligament. So now talking about the coronary arteries. These are the coronary arteries. Coronary arteries are the arteries of the heart. This is the left coronary artery. This is the right coronary artery. Coronary arteries are responsible for the blood supply to the heart. So they are derived from the epicardium. So important, they are derived from the epicardium, the outermost lining of the heart. The epicardium undergoes mesenchymal changes. So epithelial to mesenchymal transition is induced within the epicardium. And how is it induced? It is induced by the underlying myocardium. So it contributes to endothelial and smooth muscle. It contributes endothelial and smooth muscle cells to the coronary arteries. So it also contributes the endothelial cells as well as the smooth muscle cells which are present in the arteries. So cardiac neural crest cells, what do they do? How do they help in the development of coronary arteries? So the neural crest cells, which were initially present in the anterior region of the neuropore, have now migrated throughout the body, and they are now acting on the heart tube in the formation of the coronary arteries. Let's see what they do. They contribute smooth muscles along the proximal segments of the coronary artery. So along the proximal segments, they contribute the smooth muscles. So they direct the connection of coronary arteries to the aorta. So they are helping in the formation of the smooth muscles. They are also helping in the formation of appropriate vessels at the appropriate site. That is, they help in the formation of connection between the developing coronary arteries and the aorta, which are the biggest vessels in the body. The connection occurs from the ingrowth of arterial endothelial cells. This is peculiar because now the connection with the aorta occurs by ingrowth. That is, the cells grow inward of the cells of the arterial endothelium now grow inward, and they obliterate, not exactly obliterate, but they proliferate into the aorta, thereby invading it and forming a connection with it. Now, patent ductus arteriosus. So, ductus arteriosus is the connection between the pulmonary trunk. Here you can see this is the pulmonary trunk. This is the arch of aorta, and ductus arteriosus is the connection between the pulmonary trunk and the arch of aorta. So, shortly after birth, this ductus arteriosus undergoes a functional closure by muscular spasm. So, muscular spasm occurs due to changes in oxygen tension at this site, and as a result of which, this functional closure of the ductus arteriosus. Anatomical closure by means of intimal proliferation may take 1 to 3 months. So, it is a defect that can cause large differences between aortic and pulmonary pressure. Hence, it is very important to keep an eye out for patent ductus arteriosus. Now, talking about the coarctation of aorta. Here in the figure, you can see coarctation is actually indentation. So, any indentation in the aorta is coarctation of the aorta. As a result of this indentation, the lumen of the aorta narrows, and the blood, which should flow, straight streamline flow of blood should be there in aorta. It does not go that way. The blood becomes turbulent, and it is difficult for the blood to flow appropriately. So aortic lumen below the origin of the left subclavian artery is narrowed. So it usually occurs after the origin of the subclavian artery, and it is narrowed. It can be preductal or postductal. So what type of duct is present in this region? That is ductus arteriosus. So the preductal and postductal classification of the coarctation of aorta is according to the ductus arteriosus. So it is thought that there is, in this region, there is abnormality in the media of aorta, which leads to intimal proliferation, and hence an indentation or coarctation occurs. So now we'll talk about the abnormal origin of the right subclavian artery. So before getting into the detail, let's take a look on the figure. I hope you'll understand it, and you'll be able to make out how the abnormal origin of right subclavian artery takes place. So in this first figure, these are the arches of aorta, the right horn and the left horn of the dorsal aorta. So here you can see this is the left common carotid, the right common carotid. This is the brachiocephalic trunk. This is the normal location of the right subclavian artery. This segment is supposed to obliterate. Involution of this segment normally takes place to form this adult structure. This is the right common carotid, left common carotid. This is the brachiocephalic trunk. This is the right subclavian. This is the left subclavian. This is the arch of aorta. This is the descending aorta. All right. But what happens in the abnormal origin of the right subclavian artery? Now let's see. Artery is formed by the distal portion of the right dorsal aorta and seventh intersegmental artery. So this portion that lies between the seventh intersegmental artery and the distal portion of the right dorsal aorta, which was supposed to obliterate, now it persists, and this portion forms the right subclavian artery. The right fourth aortic arch and proximal part of the right dorsal aorta are obliterated. So instead of this section being obliterated, the upper portion is obliterated. So the right fourth aortic arch and the proximal part of the right dorsal aorta are obliterated. They are not there anymore. So the aorta shortens between the left common carotid and the left subclavian. So there's shortening of aorta between the left common carotid and the left subclavian arteries. Now the stem originates from the right dorsal aorta. So here you can see it is originating from the right dorsal aorta. It crosses the midline. Now here you can see it is originating from the dorsal aorta and then crossing the midline behind the esophagus. Here, this in yellow is the esophagus to reach the right arm. So this is how an abnormal right subclavian artery is formed. Don't be intimidated by it. It's simple, it's easy. Just remember the normal development and then you'll get to know the abnormal development very easily. Moving on, the double aortic arch. So what happens in this condition? The right dorsal aorta between the origin of seventh intersegmental and its junction with the left dorsal aorta persists. Again, there is persistence of this segment of the right dorsal aorta. So it results in the formation of a ring. Here you can see a vascular ring is formed around the trachea, and now this ring may compress on the structures and may result in difficulty in breathing and or swallowing. Moving on, now we have a right-sided aortic arch. So what happens in a right-sided aortic arch? The left fourth arch and left dorsal aorta are obliterated. So the left-sided fourth arch, again going back to that figure, the left-sided aortic arch now obliterates and left dorsal aorta. This left dorsal aorta and left-sided aortic arch, they completely obliterate. Now the obliteration results in the formation of there is replaced by the corresponding vessels on the right side. Here you can see these are the corresponding vessels on the right side, and this is the left dorsal aorta which has been obliterated. So occasionally a left-sided ligamentum arteriosum may interfere with swallowing. Occasionally that may be present. Here you can see this is the right-sided aortic arch which is developing from the right side due to anomalous development, and left fourth arch and left dorsal aorta has been obliterated completely. Now what is an interrupted aortic arch? As it's evident from the name, the development of aortic arch has been interrupted and there is a misconnection or a discontinuation within the aortic arch. So abnormal regression pattern in the right and left fourth aortic arches. Obviously the aortic arch was formed by the right and left fourth aortic arch. So any abnormal regression pattern in the arches may result in the faulty development of the adult aortic arch. So there's interruption between the aortic arch and the dorsal aorta, pretty obvious. There are three types. So type A, we see this is the type in which there is miscommunication between the left subclavian. Here you can see this is the left subclavian artery and the descending aorta. So there is no communication between these this arch of aorta, and the segment that is missing is between the left subclavian and the descending aorta. Then the second type, which is the most common type, in this we have a miscommunication between the left subclavian artery and left common carotid artery. Alright, so left subclavian and left common carotid are not joining with each other, but rather ending as blind tubes. So, and finally type C. In type C we have miscommunication between the between the left common carotid and the right common carotid, or the innominate artery or the brachiocephalic trunk. Here you can see in the figure there is a miscommunication between the left common carotid and the innominate artery. So these are the three basic types of the interrupted aortic arch. So, interrupted aortic arch is also associated with ventricular septal defect and a patent ductus arteriosus. Obviously, it has to be associated with these conditions because it allows the blood to reach the lower part of the body. Otherwise, there would be no blood flow to the lower part of the body, and it would not be viable with the life. It occurs in 50% of the patients with Dye-George syndrome as a part of 22q11 deletion syndrome. So Dye-George syndrome is 22q11 deletion syndrome. Here a picture of the child with the Dye-George syndrome has been attached, showing a tubular nose and a bluish hue to the skin. 50% of these patients usually have an interrupted aortic arch, type B of which is the most common between the left subclavian and the left common carotid. So this was all about this section. In this section, we saw the development of the arteries and the various clinical defects that may occur if the development of aortic arches may go wrong. It was an extensively detailed section. I would urge you to understand the development first so that you can understand the anomalies easily. Keep watching sqadia.com.